Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Dr. Jeremy Orr from Medial Early Sign, where he is the CEO and Chief Medical Officer with a couple of decades of clinical medical practice, population health, and healthcare IT experience under his belt. He is now working at Medial Early Sign. Jeremy, welcome, and thank you for joining us.
Thanks, David. Been looking forward to this.
Great. I'd appreciate it if, to set the stage, you could give us a thumbnail sketch of Early Sign so we understand what you're working on exactly and how this keys into the rest of the healthcare ecosystem.
Yeah, certainly. Early Sign is a company that started as a research organization, and the initial goal was to see what was possible applying machine learning to clinical data. Now, this began over 10 years ago, and those days AI and machine learning weren't quite the hot topics they are now, so we were a little ahead of the game. We quickly realized that there is a lot of signal in structured EMR data, and particularly lab data, that could really help healthcare providers make better decisions, particularly around earlier detection and intervention for cancers and chronic disease. And I'll elaborate on that a little bit as we go through this. So over that period of time, we've developed a series of products that are focused on helping with early detection. And our initial push was into the provider market. We're an Israel-based company as far as our development team is concerned, our data scientists, engineers, and such. And then we have our main market presence is in the United States. So we're doing our best to make a big impact on human health, and that's the basics of our approach.
There's a significant challenge there, I guess, to take that data, to build out the intelligence, to do something clinically useful. And I guess there are a number of steps along that pathway that pose significant challenges. I'm wondering, what do you see as being the requirements to do this successfully?
Yeah, it's a multi-step process, and there are some barriers. So I'll break it down into three basic stages. The first one is, how do you develop and train these algorithms? And to do that well, first of all, you need a high quality and preferably large data source. And we're very fortunate at Early Sign to have a large data set that we've accumulated from Israel, the United States, and the United Kingdom that we train our algorithms on. So you have to have the right data. You have to have a great team and infrastructure for training models, and we've built that over the years. And we have some fantastic data scientists. The talent in Israel is really exceptional. And then as part of that process, you also have to be careful about validation and biases. And there's been a lot in the press on this recently. So we're very careful to study the models on populations other than the training set and publish on them. So we have a policy of transparency. And you'll find over 14 peer-reviewed publications that are testimony to the performance of these models in different populations and such. So that's step one. That's just getting started with the training. Step two is, how do you deliver these insights in a healthcare environment? And in the United States in particular, that usually means the electronic medical record or some kind of care management platform. So we've developed an all-purpose AI calculator. We call it Algo Analyzer. An Algo Analyzer gets the data, puts it in the format needed for making the calculation, resolves the calculation, and then presents the insight for use in a clinical environment. That is no small task. That's a very important piece of technology. And then the third piece, as always, is the human element, the cultural changes that have to come with implementing any technology, and perhaps the hardest part of all. If you think about clinicians are usually very conservative in adopting new approaches to care. And there's a good reason for that. They want to be sure that it's safe and effective. And they usually want to see publications and then evidence and practice that it really works. So our publications help a little bit there, but ultimately we still have to prove the value in live practice situations. And we're in the middle of that process. We're working closely with our partners. We have two fantastic partners in the U.S., Kaiser and Geisinger. And both of them help us figure out what's the best way to get this in the care pathway? What's the best way for doctors to talk to patients about these insights? Because this is a new kind of conversation. So the cultural element is really critical too.
Sure. So is this in the field, so to speak, with Geisinger and Kaiser?
It is. Yes, we have algorithms live with both organizations, and they helped us, and they're great clinicians, have helped us figure out how to message this stuff, where to show it in the workflow, how to follow up on it. It's been a very satisfying relationship.
And is this rolled out in particular specialties or disease states or more across the board?
So our most mature product is in colorectal cancer screening. It's something called lower GI flag, and this looks at a patient's labs and age and gender, and it determines whether they may already have occult bleeding associated with things like colorectal cancer, and it flags them for a colonoscopy. So it's a pretty straightforward workflow. Flag the highest risk, scan the data, flag the highest risk patients, get them in for urgent colonoscopy so they can detect colorectal cancers and polyps and such earlier. And that is live at Geisinger, for example. And we worked closely with their team, especially the GI department, on how to get that up and running.
And presumably the value add here is that you're raising this flag where a clinician wouldn't ordinarily see it on his or her own, right?
So this is a key question, and I'm glad you asked. What are we doing that the clinician's not already doing? Because they're out there recommending screening colonoscopy at intervals and such, and they're really good at triaging labs and understanding symptoms that are concerning. So what do we bring? Number one, we bring a systematic approach. We're scanning all of that data that's out there, even historical data going back as much as 3 years, and we're finding the high-risk patients. And as you know, it's not humanly possible for people to look at all this historical data and find the highest risk patients, even using general standards. It's just too big a task. So we're taking a systematic approach. In that sense, we're providing a sort of low-cost safety net for things that might otherwise get missed. But I think more importantly, and perhaps more interesting for the clinicians in the audience, is that we can see signal in labs that doctors can't. And I'll use a simple blood count as an example. So any clinician, worth their weight can tell when a patient's anemic. And anyone knows patients of a certain age, when they're anemic of a certain type, that patient may have a hidden colorectal cancer. And one of the interventions is to get them checked out with a colonoscopy. So that's the current standard of care. But when we train these algorithms on, hundreds of thousands or millions of patients, we see subtle and non-intuitive mathematical relationships between the different parts of a blood count that appear well before the patient's anemic. So we may see a relationship between cell size and platelets or hemoglobin concentration that is like a mathematical, non-intuitive, and we can do those calculations and we can flag those patients. And a large proportion, over 70% of the patients that we flag at high risk at a certain specificity, have a totally normal looking blood count. So when I was in practice as a family doc, I would call patients that had a blood count and say, you have nothing to worry about. But what we're learning in algorithmic analysis is actually they may have some early signs that are not overt anemia yet. So we can get them to care earlier, and that means earlier detection and intervention.
Thank you. Are you at a point yet where you can say anything about the percentages or the numbers of early detection cases that have been brought to light through the use of this algorithm?
Yeah, absolutely. So again, using the same example, that's the one we have the longest track record in. So normally, when you go for your screening colonoscopy, about 1 in 300, 1 in 400 scopes will find a colorectal cancer. That's the normal yield from screening. When we flag patients, again, at a certain specificity, and the flagged patients get a scope, it's fully 1 in 5 that have abnormal findings, either advanced adenomas or colorectal cancer. So the yield goes from about 1 in 300 or 400 to about 1 in 5 have significant findings. And that rate has been consistent over a couple of implementations now. We have a large implementation in Israel that has over 800 colonoscopies done now, and the findings have been very consistent all along. And then we have very similar findings in a shorter implementation at Geisinger so far. So the numbers seem to be holding up and very consistent. Our other algorithms have similar levels of sensitivity and specificity, but of course they vary by disease state and the type of algorithm.
And sticking for a moment with the colorectal screen, do you have a sense based on the data that you have, how many years delay there would be to diagnosis in the ordinary course versus what you're able to deliver?
In a general average kind of way, obviously
Yeah.
every case varies a lot. We're able to detect about a stage and a half to 2 stages earlier than conventional methods. In other words, if you waited for a patient in normal care to become anemic or have symptoms, we can usually flag those patients about a stage and a half to 2 stages earlier.
And then just to explicitly close the circle, what does that mean in terms of patient care?
Well, colorectal cancer, like almost all cancers, has a survival curve that changes dramatically by stage. And in colorectal cancer, nearly all folks with advanced adenomas survive, and we have good sensitivity to advanced adenomas. And then it's just a curve. Survival drops down to low teen percent for most stage 4 cancers, but is usually well over 70 or 80% for most stage 1. So it's just dramatically increased chances of survival and good outcomes. And your audience probably knows this, but it turns out that earlier stages are much less expensive to treat as well.
Right. Great. Thanks for laying that out. So what are some other disease states and conditions that you're looking at? I've read something about you're looking at prediabetes, and that's an area of broad interest, given the numbers of folks who are affected with that and the ultimate cost to the system and to individuals.
Right. So a big focus area is all aspects of diabetes, spanning from pre-diabetes through to the complications of patients who have established diabetes. So we have a whole suite of algorithms that look at that whole disease progression. So yes, as you hinted, over a third of Americans have pre-diabetes now. And if we're going to prevent bankruptcy of our healthcare system, we really have a unique opportunity to intervene now and prevent a lot of them progressing to the more expensive stages. So many health systems are aggressively going after this, and they're doing it in a sort of blunt way. They're sort of addressing all pre-diabetics with diabetes prevention programs, weight loss programs, perhaps even medication like metformin. And what we're proposing is there's a better way to allocate resources, and we can look at your entirety of your pre-diabetic population, which is a very large number of people. And we can say these guys, among all the folks with prediabetes, this small group is very likely to progress in the next year. And that's where you should focus your resources first, instead of this very large group. Normally, only about 3% of patients will go from pre to full diabetes in a given year. So it does make sense to allocate resources more sharply. And so that's the starting point. Now, once a patient has diabetes, we have other algorithms that look at what's their likelihood of getting chronic kidney disease, another expensive complication, or coronary artery disease, heart disease. So we're trying to address the entire spectrum there and help docs with each stage make better decisions. So that's our work in diabetes. And I'll just add briefly, we have other work in cancer screening. Another big one is lung cancer. Lung cancer screening is really just getting stood up in the Western world as the studies have shown a survival benefit to low-dose CT use for detecting it earlier. And we're helping find those candidates, very similar to the colorectal cancer work. And then I would be, of course, remiss if I didn't mention we're also doing work in COVID and influenza, the hottest topics right now, helping find the patients who are most likely to have complicated courses like hospitalization, like visit to the intensive care unit or intubation or mechanical ventilation, so that those patients can be prioritized for vaccination, contact tracing, and other treatment options.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Jeremy Orr at Medial Early Sign. Jeremy, you started to talk about COVID, and everything that we talk about this year is really related to COVID one way or another. And I'm wondering if you could say a little bit more about how you see the tools that you're building as helping to address the pandemic and also addressing the needs of a healthcare system that emerges from the other side?
I think that second point is a critical one that most people miss in this pandemic. So first, about COVID itself, we early on in the pandemic and back in February and early March, we realized that our core business around chronic disease and cancer screening would be disrupted, but that we had an opportunity to help with the pandemic. So we quickly mobilized with our partners and trained an algorithm that looks at patients who have tested positive and helps healthcare providers understand which ones are most likely to run into a complicated course. And we know now, and I think most people know from the popular press, that there's a breakdown by age and that males are a little bit worse and that people with chronic diseases do a little bit worse. But we wanted to do it systematically and train it by data. So we succeeded in doing that. And we actually now have that algorithm live at 2 health systems, and it's in workflow helping doctors make decisions as patients test positive about what their triage should be, whether they can be safely managed at home, whether they need closer attention. Now, as treatment options progress and as hopefully a vaccine comes online, the use case will change. And it will change from prioritizing testing and triage to prioritizing the vaccine. Almost certainly in the initial months of a vaccine, there will only be enough for the highest risk populations, as the CDC has already put out some guidelines that, frontline healthcare workers and others will be prioritized, and that's totally appropriate. But beyond that, we want to help algorithmically find the patients who will be highest risk. We think we have an opportunity to do that, and we're working with some health systems now to implement that so that they'll be ready for those kind of decisions. And then they can do special outreach to those patients and make sure that they are among the first to get vaccinated. So that's what the next few months look like. But I want to switch to this other topic, which is what's happening in the rest of healthcare delivery during the pandemic. So I think everybody knows that volume dropped dramatically in most situations below 50% of normal sort of routine care volume. We know that cancer screening largely stopped. And there are some interesting studies that show that we're looking at an excess cancer burden in the coming years because of this missed screening.
Right.
And that's really tragic. These are the silent victims of COVID. And then there's, of course, the chronic disease. We already talked about diabetes, but imagine you didn't see your doctor for 6 months and you're, a poorly controlled diabetic. Now you're more likely to have complications and your course be accelerated. So how do we help with this? So there's 2 things we think we can help with. Number one is just simple restoration of patients' faith in the healthcare system. And so they need to understand that, they do need this care. They do need to get back to their cancer screening and their chronic disease care, and that their healthcare provider is providing a safe environment for doing that, or alternative options like telehealth where it applies. So what we're doing there is creating a list of high-risk patients that present an opportunity for outreach for these health systems. And they're grateful for that because they want to reach out to the highest risk patients first. The second thing is simply putting them to the front of the line and making sure they're not forgotten about. So we talked before about the sort of low-cost safety net aspect of lower GI flag. This is similar. We're scanning the data. We're finding the near-term emergencies and say, get in and see your doc about your diabetes now, because there's a signal here that suggests that you might get into trouble first, and you really need it. And that also changes the conversation between the doc and the patient. We're giving the docs ammunition to convince them to come back in, that it is a little bit more urgent. Yes, they do need to come in and comply. And that shared decision-making goes a lot better when we give them something to work with. So we're very proud of that. We have that campaign we're calling Back to Care, and it's all about driving that return to routine stuff.
It sounds like the frontline clinicians have a pretty good feel for what you're doing and a positive perception of what you're doing. Is that fair to say, or do you receive any sorts of resistance from frontline clinicians?
It's really interesting going through the implementation process and seeing how docs respond. I think that when we have the conversation about what we can see in labs that they can't, it's eye-opening. And it's a little bit humbling for docs because we're well-trained, and we like to think that if there's something wrong in a lab, we're going to be able to find it. The truth is that algorithms like ours and others can augment care in very important ways and do things that humans can't. That's a wake up moment for a lot of docs. But to their credit, as soon as they realize it, then they start to think, okay, I really need to start using this in my practice to do my best for my patients. So that's a game changer. Now, there's a really key part of implementation where when you flag a patient as high risk, the doctor tends to want to reconcile it with their clinical judgment. And we've had this experience where we flag a patient as high risk and the doc goes back to the chart. And the first thing they do is they beat themselves up a little bit and they say, what did I miss? And they'll go through all the labs and the history and they'll say, I don't know why this patient is flagged as high risk when I thought they were fine all along. And that's a sort of troubling feeling when you get that as a clinician. And every doctor has, I think, a conscience about this and stays up late at night thinking about what they missed. So what we have to do in the clinical machine learning realm is do a better job of explaining how the algorithm found that patient. So at Early Sign, we've developed a feature called But Why for all of our algorithms. These algorithms are often criticized as being black box. And there's some truth to that because the mathematical stuff can't always be explained well. But with But Why, we've created a way to go at least part of the way there and show some of the clinical features that landed that patient on that list. And that changes the dynamic dramatically because now the doctor can say, we'll say this patient landed because of this trend in platelets and this trend in cell size. And then now they'll go back and if they look at the last few blood counts, they can see it too. And they say, okay, it makes sense. It's just that the computer's more sensitive to it than I am, but I can see some of this change. And now they trust the algorithm more. The other thing it does is it gives them, again, ammunition for a better conversation with the patient. Because imagine, you're being told by your doctor, this algorithm picked you as high risk. You need to go get a colonoscopy. Most patients are going to respond, well, can you say a little bit more, please? I need a better explanation. But Why gives them some of the clinical features that help them explain it consistent with their usual types of clinical explanations. So we think But Why is going to be critical to getting over some of these implementation barriers.
Right. That makes a lot of sense, both for the clinician and for the patient. So stepping back and looking more broadly, how do you see what you're doing intersecting with other trends in AI and machine learning in healthcare? What's the challenge and what's sort of the landscape of opportunity here?
So I think that the two places where machine learning in medicine are where it's most advanced are in imaging and in administrative tasks. And there's a good reason for that. I mean, imaging was the first place to use machine learning because images are, what data scientists like to call completely classified. All the information is there and you have a result and it's easy to train algorithms on that. The other place where there's close to complete classification is in administrative tasks, scheduling, optimizing a revenue cycle, things like that. The world we're working in, clinical data, is far messier. So electronic medical records are essentially transactional tools. They're not high fidelity data capture tools. So there's a lot of fat-fingered entries. And one of my colleagues used to like to say, men having babies and 1,000-year-old people in there. And so you have to do a lot of data prep work, cleaning, normalization before you can even begin to think about training a model. So that it takes that kind of work, and then you can start to get the insights. So for that reason, the kind of work we're doing at clinical machine learning on EMR data and labs is a little bit further behind imaging and others. We're further back in the adoption curve. Let me move forward to about 5 or 7 years from now. I think that the kind of risk stratification we're doing will be in very widespread use. But the next 5 to 7 years are critical in driving that adoption curve. And that's the hard work we're doing now. There's no shortcuts to that. It takes developing the delivery technology well. It takes all these validation studies. It takes the cultural transformation that I described. And it's going to take a little bit of work to get the credibility built up and the acceptability built up. And that's why we're working with organizations now on publishing on our results, on them going out and talking about the work. So that's just going to take time.
And that's my wrap-up question, is really sort of looking into the future, sort of 5 years from now. What do you think is going to be different? What if you woke up tomorrow, 5 years in the future, what would have changed dramatically in healthcare?
Well, I'm fond of the term data tranquility. So if you think about a primary care physician in the middle of practice today, they're still seeing patients one at a time. They may see 25 a day, either in the office or now with telemedicine. But behind them is a mountain of data from all the prior visits, from all the telephone encounters, from all the labs that have been done, from all the care that was delivered by other clinicians. And they're responsible for that. In a theoretical sense, they have a panel of patients and they want the best outcomes for all of their panel. So I think the first step is that machine learning will bring some sense of data tranquility to the physician by scanning all that data and doing what we're doing now, essentially risk stratification, and putting the highest risk patients right in front of them, even when they're not seeing them. So I think that's near term. I think that will happen in the next few years, and we'll be a part of it at Early Sign. The next thing, again, beyond the 5 to 7 years, I think the holy grail of machine learning in clinical medicine is prescriptive advice. So right now we're doing essentially prediction and description, and it's an important starting place. They're familiar use cases. But where the computer can really make a difference is advising the best treatment paths for patients based on the data available and based on historical outcomes of other patients that are similar to them. This is a much harder data science problem. It hinges on concepts like causal inference, and these aren't completely solved technical problems. But I think ultimately that's going to have a much, much bigger impact on care delivery downstream.
Well, certainly something to look forward to. Thank you, Jeremy.
Thanks, David. Really enjoyed it.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.